Hello, and welcome back to another chapter of Advanced Pharmacology. Today we're discussing chapter 63, Laxatives. Laxatives are used to ease or stimulate defecation. These agents can soften the stool, increase stool volume, hasten fecal passage through the intestine, and facilitate evacuation from the rectum. When properly employed, laxatives are valuable medications. However, these agents are also subject to abuse. Misuse of laxatives is largely the result of misconceptions about what constitutes normal bowel function. Before we talk about laxatives, we need to distinguish between two terms, the laxative effect and catharsis. The term laxative effect refers to the production of a soft, formed stool over a period of 1 or more days. In contrast, the term catharsis refers to a prompt fluid evacuation of the bowel. Hence, a laxative effect is slower and relatively mild, whereas a catharsis is relatively fast and intense. So, general considerations. The function of the colon. The principal function of the colon is to absorb water and electrolytes. Absorption of nutrients is minimal. Normally, about 1.5 liters of fluid enters the colon each day, and about 90% gets reabsorbed or absorbed. When the colon is working correctly, the extent of fluid absorption is such that the resulting stool is soft and capable of elimination without strain. However, when fluid absorption is excessive, as can happen when transport through the intestine is delayed, the resulting stool is dehydrated and hard. Conversely, if insufficient fluid is absorbed, watery stools result. Frequency of bowel evacuation varies widely among individuals. For some people, bowel movements occur 2 to 3 times a day. For others, elimination occurs only 2 times a week. Because of this wide individual variation, we can't define a normal frequency for bowel movements. Put another way, although a daily bowel movement may be normal for many people, it may be abnormal for many others. Dietary fiber. Proper function of the bowel is highly dependent on dietary fiber, the components of vegetable matter that escapes digestion in the stomach and small intestine. Fiber facilitates colonic function in two ways. First, fiber absorbs water, thereby softening the feces and increasing their mass. Second, fiber can be digested by colonic bacteria, whose subsequent growth increases fecal mass. The best source of fiber is bran. Fiber can also be obtained from fruits and vegetables. The ingestion of 20 to 60 grams of fiber a day should optimize intestinal function. Constipation. Constipation is one of the most common gastrointestinal disorders in the United States. People seek medical help for constipation at least 2.5 million times a year and spend hundreds of millions of dollars on laxatives. Constipation is defined in terms of symptoms, which include hard stools, infrequent stools, excessive straining, prolonged effort, a sense of incomplete evacuation, and unsuccessful defecation. Scientists who do research on constipation usually define it using the Rome 3 criteria. Constipation is determined more by stool consistency, the degree of hardness, than of how often bowel movements occur. Hence, if the interval between bowel movements becomes prolonged, but the stool remains soft and hydrated, a diagnosis of constipation would be improper. Conversely, if bowel movements occur with regularity, but the feces are hard and dry, constipation can be diagnosed, despite the regular and frequent passage of stool. So, here is an excellent spot to hit pause so you can review the Rome 3 criteria of what is considered constipation. A common cause of constipation is poor diet, specifically a diet deficient in fiber and fluid. Other causes include a dysfunction of the pelvic floor and anal sphincter, slow intestinal transit, and the use of certain drugs. such as your opioids, anticholinergics, and some antacids. In most cases, constipation can be readily corrected. Stools will become softer and more easily passed within days of increasing fiber and fluid in the diet. Mild exercise, especially after a meal, also helps improve bowel function. If necessary, a laxative may be employed, but only briefly and only as an adjunct to improve the diet and exercise, leading us to patient-centered care across the lifespan. Again, an excellent spot to hit pause so you can review. The indication for laxative use. Laxatives can be highly beneficial when employed for valid indications. By softening the stool, laxatives can reduce the painful elimination that can be associated with episiotomy and with hemorrhoids and other anorectal lesions. In patients with cardiovascular disease, such as aneurysms, myocardial infarcts, disease of the cerebral or cardiac vasculature, softening the stool decreases the amount of strain needed to defecate, avoiding dangerous elevation of blood pressure. In older adults, laxatives can help compensate for the loss of tone in abdominal and perineal muscles. As an adjunct to the antithalamic or anthelmintic therapy, laxatives can be used for obtaining a fresh stool sample for diagnosis, emptying the bowel before treatment, and facilitating export of dead parasites after anthelmintic use. Additional applications include the emptying of the bowel before surgery and diagnostic procedures, the radiologic examination, a colonoscopy, modifying the effluent from the ileostomy or colostomy, preventing fecal impaction in bedridden patients, and removing ingested poisons. And lastly, the correcting constipation associated with pregnancy and certain drugs, especially opioid analgesics. The precautions and contraindications for laxative use. Laxatives are contraindicated for individuals with certain disorders of the bowel. Specifically, laxatives must be avoided by individuals experiencing abdominal pain, nausea, cramps, and other symptoms of appendicitis, regional enteritis, diverticulitis, and ulcerative colitis. Laxatives are also contraindicated for patients with acute surgical abdomen. In addition, laxatives should not be used in patients with fecal impaction or obstruction of the bowel because increased peristalsis could cause bowel perforation. Lastly, laxatives should not be employed habitually to manage constipation. Reasons for this are discussed under laxative abuse. Laxatives should be used with caution during pregnancy because GI stimulation may induce labor, and during lactation because the laxatives may be excreted in breast milk. Laxative classification schemes. Traditionally, laxatives have been classified according to their general mechanism of action. This scheme has four major categories, whether it's bulk-forming laxatives, surfactant laxatives, stimulant laxatives, or osmotic laxatives. Representative drugs are shown here in the following table, and it's an excellent time to hit pause so you can see all the different types. Again, the big ones or the four major classes are the bulk forming, surfactant, stimulant, osmotic, but there are also miscellaneous. From a clinical perspective, it can be useful to classify laxatives according to their therapeutic effect, time of onset, and effect on stool consistency. When these properties are considered, most laxatives fall into one of the three category groups, labeled 1, 2, and 3 in this chapter. Your Group 1 agents act rapidly, usually within 2 to 6 hours, and give a watery consistency to the stool. Laxatives in the Group 1 are especially useful when preparing the bowel for diagnostic procedures or surgery. Group 2 agents have an intermediate latency, so anywhere between 6 to 12 hours, and produce a stool that is semi-fluid. Group 2 agents are the ones most frequently abused by the general public. And lastly, we got the group 3 laxatives, which are slow acting, usually 1 to 3 days, to produce a soft but formed stool. Use of this group include the treatment of chronic constipation and the prevention of straining at stooling. Representative members of group 1 through 3 are shown here in the following table. So again, here's an excellent spot to hit pause so you can see the different types that are given. So let's start off with the basic pharmacology of laxatives. Your bulk forming laxatives. The bulk forming laxatives, such as methylcellulose, psyllium, and polycarbophil, have actions and effects much like those of a dietary fiber. These agents consist of natural and semi-synthetic polysaccharides and cellulose derived from grains and other plant material. The bulk forming agents belong to our therapeutic group 3, producing a soft, formed stool in 1 to 3 days. So, how do they work? The mechanism of action. Bulk forming agents have the same effect on bowel function as dietary fiber. Again, after the ingestion, these agents, which are non-digestible and non-absorbable, swell in water to form a viscous solution or gel, thereby softening the fecal mass and increasing its bulk. Fecal volume may be further enlarged by growth of colonic bacteria, which can utilize these materials as nutrients. Transit through the intestine is hastened because swelling of the fecal mass stretches the intestinal wall and thereby stimulates peristalsis. So how is it indicated, or when would it be indicated? Your bulk forming laxatives are preferred agents for temporary treatment of constipation. Also, they are widely used in patients with diverticulosis and irritable bowel syndrome. In addition, by altering fecal consistency, they can provide symptomatic relief of diarrhea and can reduce discomfort and inconvenience for patients with an ileostomy or a colostomy. Your adverse effects. Untoward effects are minimal because the bulk forming agents are not absorbed. Systemic reactions are rare. Esophageal obstruction can occur if they are swallowed in the absence of sufficient fluid. Accordingly, bulk forming laxatives should be administered with a full glass of water or juice. If their passage through the intestine is impeded, they may produce intestinal obstruction or impaction. Accordingly, they should be avoided if there is narrowing of the intestinal lumen. So your preparation, dosage, and administration. Psyllium, the prepared from plantago seed, methylcellulose, and polycarbophil, are the principal bulk-forming laxatives. All three preparations should be administered with a full glass of water or juice. Dosages and trade names are followed here on this following table. Again, a great place to hit pause if you're unfamiliar. Surfactant laxatives. Its actions. The surfactants, such as docosahexaene sodium, are a group 3 laxative. They produce a soft stool several days after the onset of treatment. Surfactants alter stool consistency by lowering surface tension, which facilitates penetration of water into the feces. The surfactants may also act on the intestinal wall by inhibiting the fluid absorption and stimulate secretion of water and electrolytes into the intestinal lumen. In this respect, surfactants resemble the stimulant laxatives. So its preparation, dosage, and administration. The surfactant family consists of two docosahexaene salts, docosahexaene sodium and docosahexaene calcium. The dosage for docosahexaene sodium or cholase, the prototype surfactant, is shown here in the following table. Administration should be accompanied by a full glass of water. So prototype drugs, your laxatives, your bulk forming agents, such as your methylcellulose, your surfactant, again, your docosahexaene sodium. Your stimulant laxative would be your bisacodyl, your osmotic laxatives would be your magnesium hydroxide, and your chloride channel activator would be your lubiprostone. Bringing us to stimulant laxatives. The stimulant laxatives, or bisacodyl, senna, and castor oil, have two effects on the bowel. First, they stimulate intestinal motility, hence their name, stimulant. Second, they increase the amount of water and electrolytes within the intestinal lumen by increasing the secretion of water and ions into the intestine and by reducing the water and electrolyte absorption. Most stimulant laxatives are a group 2 agent. They act on the colon to produce a semi-fluid stool within 6 to 12 hours. Stimulant laxatives are widely used and abused by the general public and are a concern for this reason. They have few legitimate applications. Two applicants are general legitimate: the treatment of opioid-induced constipation and the treatment of constipation resulting from slow intestinal transit. Properties of individual agents are discussed next. So, the first one is bisacodyl. Bisacodyl, also known as Dulcolax, is unique among the stimulant laxatives in that it can be administered by a rectal suppository, as well as orally. Oral bisacodyl acts within 6 to 12 hours. Hence, tablets may be given at bedtime to produce a response the following morning, whereas the suppositories can act rather rapidly, within 15 to 60 minutes. Dosages for bisacodyl are shown in table 63.4. Your bisacodyl tablets are enteric-coated to prevent gastric irritation. Accordingly, patients should be advised to swallow them intact without chewing or crushing. Because milk and antacids accelerate the dissolution of the enteric coating, the tablet should be administered no sooner than 1 hour after ingesting these substances. Bisacodyl suppositories may cause a burning sensation, and with continued use, proctitis may occur. Accordingly, long-term use should be discouraged. That brings us to our second classic, your senna. Sennicat is a plant-derived laxative that contains anthraquinones as an active ingredient. These actions and applications of senna are similar to those of bisacodyl. Anthraquinones act on the colon to produce a soft or semi-fluid stool in 6 to 12 hours. Systemic absorption, followed by renal secretion, may impart a harmless yellow, brown, or pink color to the urine. Dosages, again, are presented on that table 63.4. Castor oil. Castor oil is the only stimulant laxative that acts on the small intestine. As a result, the drug acts quickly, in 2 to 6 hours, to produce a watery stool. Hence, unlike other stimulant laxatives, which are all group 2 agents, castor oil belongs to group 1. The use of castor oil is limited to situations in which rapid and thorough evacuation of the bowel is desired. Again, if you're doing a preparation for radiologic procedures, such as a colonoscopy. The drug is far too powerful for routine treatment of constipation. Because of its relative prompt action, castor oil should not be administered at bedtime. The drug has an unpleasant taste that can be improved by chilling and mixing with fruit juices. Which brings us to the osmotic laxatives. Your osmotic laxatives are your laxative salts, so their action and use. Laxative salts, your sodium phosphatate, your magnesium hydroxide, are poorly absorbed salts whose osmotic action draws water into the intestinal lumen. Accumulation of water causes a fecal mass to soften and swell, thereby stretching the intestinal wall, which stimulates peristalsis. When administered in low doses, the osmotic laxative produces a soft or semi-fluid stool in 6 to 12 hours. In high doses, these agents act rapidly and can cause a stool to form in 2 to 6 hours. To cause a fluid evacuation of the bowel, high-dose therapy is employed to empty the bowel in preparation for diagnostic and surgical procedures. High doses are also employed to purge the bowel of ingested poisons and to evacuate dead parasites after anthelmintic therapy. So, how is it prepared? We have two groups of laxative salts. Again, we have your magnesium salts, so your magnesium hydroxide, magnesium citrate, and magnesium sulfate. And then we have the one sodium salt, which is sodium phosphate. Dosages for magnesium hydroxide solutions, also known as milk of magnesia, and sodium phosphate, again, are shown on the table 63.4. So, what are some adverse effects? Osmotic laxatives can cause substantial loss of water. To avoid dehydration, patients should increase fluid intake. Although the osmotic laxatives are poorly and slowly absorbed, some absorption still takes place. In patients with renal impairment, magnesium can accumulate to a toxic level. Accordingly, magnesium salts are contraindicated in patients who have kidney disease. Sodium absorption from sodium phosphate can cause fluid retention, which in turn can exacerbate heart failure, hypertension, and edema. Accordingly, sodium phosphate is contraindicated for patients with these types of disorders. Sodium phosphate can also cause acute renal failure in vulnerable patients, especially those with kidney disease and those taking drugs that alter renal function. So, anyone who's taking, for instance, diuretics, angiotensin converting enzymes, so your ACE inhibitors, angiotensin receptor blockers, or ARBs. The mechanism involves the dehydration and the precipitation of calcium and phosphate in renal tubules. Accordingly, sodium phosphate should be avoided in this vulnerable group. Bringing us to our polyethylene glycol, or more commonly known as Miralax. Miralax is an osmotic laxative used widely for chronic constipation. Like the laxative salts, PEG is a non-absorbable compound that retains water in the intestinal lumen, causing the fecal mass to soften and then swell. The most common adverse effects are nausea and abdominal bloating, cramping, and gas. High doses can cause diarrhea. For the management of chronic constipation, PEG is a superior to lactulose with regard to relief of abdominal pain and the improvement in stool consistency, and frequency per week. Although side effects are similar, the recommended dosage is 17 grams once a day, dissolved in 4 to 8 ounces of water, juice, soda, coffee, or even tea. Your bowel movement may not occur for another 2 to 4 days. As discussed later, products that contain PEG plus electrolytes can be used to cleanse the bowel for colonoscopy and other procedures. Which brings us to lactulose. Lactulose is a semi-synthetic disaccharide composed of galactose and fructose. Lactulose is poorly absorbed and cannot be digested by intestinal enzymes. In the colon, resident bacteria metabolize lactulose to lactic acid, forming acid and acetic acid. These acids exert a mild osmotic action, producing a soft form stool in 1 to 3 days. Although lactulose can relieve constipation, this agent is more expensive than equivalent drugs and causes more unpleasant side effects, again, gas and cramping. Accordingly, lactulose should be reserved for patients who do not respond adequately to bulk forming agents. In addition to its laxative action, lactulose can enhance intestinal excretion of ammonia. This property has been exploited to lower blood ammonia content in patients with portal hypertension and hepatic encephalopathy secondary to chronic liver disease. bringing us to other laxatives. One of such is the lubiprostone, or Amitiza, which is the first representative of a new class of drugs, the selective chloride channel activators. By activating the chloride channel in epithelial cells lining the intestine, lubiprostone promotes secretion of chloride-rich fluid into the intestine and enhances motility in the small intestine and colon. The result is spontaneous evacuation of a semi-soft stool, usually within 24 hours. Lubiprostone has three indications: chronic idiopathic constipation in adults, irritable bowel syndrome with constipation in women at least 18 years of age, and the treatment of opioid-induced constipation and chronic non-cancer pain. In clinical trials, the drug reduced constipation severity and abdominal bloating and discomfort. Lubiprostone is taken orally, and very little is absorbed. Nausea is the most common side effect and can be reduced by taking lubiprostone with food and water. Other GI effects include diarrhea, abdominal distension, abdominal pain, gas, vomiting, and loose stools. Headache is the major non-GI effect. A small percentage of patients experience difficulty breathing in association with a sense of tightness in the chest, starting 30 to 60 minutes after the first dose, and resolving in a few hours. Lubiprostone is categorized by the FDA pregnancy risk group as Category C and should not be used only if the benefits are deemed to outweigh the potential risk to the fetus. Interactions with other drugs have not been studied but seem unlikely because lubiprostone is poorly absorbed and doesn't alter the activity of cytochrome P450, drug metabolizing enzymes. Lubiprostone is available in 8 and 24 microgram soft gelatin capsules that should be taken with food and water. The recommended dosage is 24 micrograms twice daily for constipation and 8 micrograms twice daily for IBS. The role of lubiprostone is going to get discussed further for IBS in chapter 64. Your mineral oils. Mineral oil is a mixture of indigestible and poorly absorbed hydrocarbons. Laxative action is produced by lubrication. Mineral oil is especially useful when administered by enema or treat fecal impaction. Mineral oil can produce a variety of adverse effects, however. The aspiration of oil droplets can cause lipid pneumonia. Anal leakage can cause pruritus and soiling. Systemic absorption can produce deposition of mineral oil in the liver, and excessive dosing can decrease absorption of fat-soluble vitamins. Dosages for adults and children are shown in Table 63.4. Your glycerin suppositories. Glycerin is an osmotic agent that softens and lubricates inspissated or hard-impacted feces. The drug may also stimulate rectal contraction. Evacuation occurs about 30 minutes after the suppository is inserted. Your glycerin suppositories have been used for the reestablishing of normal bowel function after the termination of a chronic laxative use. Bringing us to bowel cleansing products for a colonoscopy. A colonoscopy is the most effective method for the early detection of colorectal cancer, the second leading cause of cancer in the US. Before the procedure, however, the bowel must be cleansed to permit good visualization. Three kinds of bowel cleansers are used in this aspect: sodium phosphate, a combination of sodium picosulfate, magnesium oxide, and citric acid, and a PEG plus electrolytes. The PEG ELS products are isotonic with body fluids and hence do not alter water or electrolyte status. In contrast, the sodium phosphate and the combination products are hypertonic and cause dehydration and electrolyte disturbances. In addition, the sodium phosphate products can cause kidney damage. However, despite their greater potential for harm, the sodium phosphate products have better patient acceptance because the PEG ELS products require ingestion of a large volume of liquid, whereas the sodium phosphate products do not. Nonetheless, sodium phosphate products should be avoided by patients that are at risk, including those with electrolyte abnormalities, renal impairment, and hypovolemia. Representative bowel cleansers are shown here in Table 63.5. Again, an excellent spot to hit pause so you can review them. The first one we're going to talk about here is the polyethylene glycol electrolyte solution. These bowel cleansing solutions, your Go Lightly, contain PEG, a non-absorbable osmotic agent, together with ELS, usually your potassium chloride, your sodium chloride, sodium sulfate, and sodium bicarbonate. The mixture is isomotic with body fluids, and hence water and electrolytes are neither absorbed nor secreted in the intestinal lumen. As a result, dehydration does not occur, and the electrolyte balance is preserved. Because water effects on the electrolytes are minimal, PEG-ELS solutions can be used safely by patients who are dehydrated and by those who are especially sensitive to the alteration of electrolyte levels, so patients who have renal impairment or cardiovascular disease. With traditional PEG-ELS products, your Go Lightly, the volume administered is huge, typically 4 liters, and patients must ingest about 25 or 250 to 300 ml every 10 minutes for 2 to 3 hours. With two newer products, Half Lightly and Movie Prep, the volume is cut in half. Patients using Half Lightly take a stimulant laxative, bisocodyl, along with the PEG-ELS solution and do not need to take the full 4-liter dose. Volume reduction with Movie Prep is possible owing to the addition of ascorbic acid and a sodium ascorbate to the PEG-ELS solution with all PEG products. Bowel movements commence about 1 hour after the first dose. PEG-ELS products are generally well tolerated. The most common adverse effects are nausea, bloating, and abdominal discomfort. These effects are less intense with the reduced volume formulations. Because PEG-ELS products don't alter water and electrolyte status, they are safer than the sodium phosphate products for patients with electrolyte imbalances, heart failure, kidney disease, or advanced liver disease. Sodium phosphate products. Again, as discussed previously, sodium phosphate is an osmotic laxative that draws water into the intestinal lumen, which then softens and swells the fecal mass, which then stretches the intestinal wall to stimulate peristalsis. Dosing consists of swallowing tablets along with a large volume of water or some other clear liquid. Because the clear liquid is more palatable than the PEG-ELS solutions, patients find the sodium phosphate regimen more appealing. Like the PEG-ELS products, the sodium phosphate products can cause nausea, bloating, and abdominal discomfort. In addition, the sodium phosphate products can cause adverse effects not seen with the PEG-ELS products, especially your dehydration, electrolyte disturbances, and kidney damage. By drawing a large volume of fluid into the intestinal lumen, sodium phosphate can cause dehydration. To prevent dehydration, patients must drink a large volume of clear fluid before, during, and after dosing. Rarely, phosphate is absorbed in amounts sufficient to cause hyperphosphatemia, which can cause acute reversible renal damage and possibly chronic irreversible renal damage. Risk factors for hyperphosphatemia and kidney damage include hypovolemia, advanced age, delayed bowel transit, active colitis, pre-existing kidney disease, and the use of drugs that could alter kidney function, including diuretics, ACE inhibitors, your ARBs, and nonsteroidal anti-inflammatory drugs. Patients who have these risk factors should probably use the PEG-ELS product rather than a sodium phosphatate. Leading us to the combo products. One combination product, magnesium oxide, and hydrocitric acid sodium picosulfate, PrEP-OPIC, the nicer way of saying it, is approved for the preparation for a colonoscopy in adults. Sodium picosulfate is a stimulant laxative, and magnesium oxide and citric acid combine to form magnesium citrate, an osmotic laxative. When given in a split-dose regimen, results are superior to colon preparation with PEG-ELS. Yprep is given in a split-dose regimen. It is supplied in 2 packets, each containing about 16.1 grams, each of powder that must be mixed with water for the consumption. The first dose is taken the evening before the colonoscopy, and the second dose the next morning before the procedure. As with sodium phosphate products, PrEP-OPIC can cause electrolyte and fluid imbalances, renal impairment, seizures, and dysrhythmia secondary to the electrolyte abnormalities, so therefore caution must be employed in patients with reduced renal function. The most common adverse reaction is nausea, headache, and vomiting. Laxative abuse. Laxative abuse. The causes. Many people believe that the daily bowel movement is a requisite of good health, and that any deviation from this pattern merits correction. Such misconceptions are reinforced by aggressive marketing of over-the-counter laxative preparations. Not infrequently, the combination of tradition supported by advertising has led to habitual self-prescribing of laxatives by people who don't actually need them. Laxatives can help perpetuate their own use. Strong laxatives can purge the entire bowel. When this occurs, spontaneous evacuation is impossible until bowel content has been replenished, which can take 2 to 5 days. During this time, the laxative user, having experienced no movement of the bowel, often becomes convinced that constipation has returned. In response, he or she takes yet another dose, which purges the bowel once more, and thereby sets the stage for a repeating cycle of laxative use and purging. So the consequences. Chronic exposure to laxatives can diminish defecatory reflexes, leading to further reliance on laxatives. Laxative abuse may also cause more serious pathologic changes, including electrolyte imbalances, dehydration, and colitis. So, the treatment. The first step is breaking the laxative habit, is abrupt cessation of laxative use. After the drug's withdrawal, bowel movements will be absent for several days. The patient should be informed of this fact. Any misconception that the patient has regarding bowel function should be corrected. The patient should be taught that once daily bowel movement may not be normal for him or her, and that stool quality is more important than frequency or quantity. Instruction on bowel training, healing the defecatory reflex, establishing a consistent time for bowel movements should be provided. Increased consumption of fiber, your bran, fruits, vegetables, and fluid should be stressed. The patient should be encouraged to exercise daily, especially after meals. Finally, the patient should be advised that if a laxative must be used, it should be used briefly and in the smallest effective dose. Agents that produce catharsis should always be avoided. And that completes our chapter here today. I thank you all for listening, and I'll see you at the next chapter, other gastrointestinal drugs. I'll see you there. Thank you.